Hello, my name is Jeffrey Kuo, and I'm Clinical Professor of Radiation Oncology at the University of California, Irvine, along with my co-author, Mark Linsky of the Department of Neurological Surgery. I thank you for taking the time to learn about the history of radiation therapy and radiosurgery. Radiation oncology and neurosurgery have a long common history treating neoplastic and non-neoplastic disease, and I hope as you learn about the history of the field that you'll appreciate how essential each field has been to the other. This timeline slide is quite busy, as they oftentimes are, but I hope I'll be able to divide the events into coherent sections. First will be discovery, in which the pioneering scientists both discovered and characterized X-rays and natural radioactivity. Soon thereafter followed a time when radiation was being discovered as effective in the treatment of malignant disease. Even from the very earliest days, neurosurgeons were key to the development of radiation therapy as an effective modality for cancer care. A number of technological developments were necessary, particularly to develop increasingly more powerful radiation generators that would be needed to treat deep-seated tumors. And not just technological developments were necessary. Scientific knowledge was also needed in order to describe and understand how radiation interacted with both normal and living tissue. And this would be the field that would eventually be called radiation biology. Just as important as the development of radiation generators was the development and application of increasingly more accurate and useful imaging technologies such as CT and MRI. There was a number of interesting radiations apart from ionizing radiation and natural radioactivity that were systematically discovered and also experimented with. Unfortunately, many of these did not turn out to be that useful. However, we'll be taking a look at several examples during the course of the lecture. And as said before, neurosurgeons and neurosurgical applications have been essential to the development of the field, not just in the early days, but also through its maturity through the second half of the 20th century and up to the present day. And in fact, I'll show that both neurosurgical applications as well as developments in science and computational technology have also driven the field in important ways. By common acclaim, Konrad Röntgen, along with Henri Becquerel and the Curies, are generally recognized as the forebears of both the fields of radiology and radiation oncology. Röntgen discovered and quickly reported his discovery of a hitherto unknown radiation which he had discovered while working with cathode ray tubes. He dubbed this new type of radiation X-rays, sometimes also known as Röntgen rays. Natural radioactivity was discovered by Henri Becquerel in 1896. Becquerel had been interested in the phenomenon of phosphorescence, and intrigued by Röntgen's reports of phosphorescence caused by X-rays, Becquerel knew that uranium salts phosphoresced when exposed to sunlight. However, in a now famous anecdote, Becquerel discovered that uranium salts could fog a photographic plate, even when the plate was shielded from the sunlight. His investigations demonstrated another type of radiation, now known as natural radioactivity. Here you see Henri Becquerel in his laboratory, and on the left side of the screen is an autoradiograph showing two crystals of the uranium salt exposing the photographic plate, even though the plate had been shielded from the sunlight. This is the effect, now called autoradiography, of the radioactivity. Pierre and Marie Curie further investigated natural radioactivity by isolating the reactive elements polonium and radium. Her demonstration that radioactivity is a property of the atom itself is in many ways her most important contribution to physics. Here is an artist's rendition of the moment when the Curies realized from the glow given off by the radium that they had isolated that they had successfully isolated the isotope. Once X-rays and radioactivity had been established as scientific fact, and moreover that radiation had biological effects such as dermatitis and inflammation, it was not long before early clinician researchers began to apply radiation to cancer treatments. Here are several examples of early cancer therapy with either radium applicators in an early form of brachytherapy in the picture on the left, or with X-ray therapy, such as the picture on the right. Early treatment devices of the 1910s and 1920s consisted of X-ray tubes capable only of generating low-energy X-rays which had poor tissue penetration capabilities. These early units would be ideal for treating skin cancer, such as the successfully treated lower lip cancer, but would be incapable of treating more deep-seated tumors. Here's an example of a X-ray therapy unit. Neurosurgeons were amongst the earliest clinicians to embrace the anti-neoplastic potential of X-ray therapy. The earliest neurosurgical report of X-ray treatment was Gramena's application of X-rays to treat acromegaly in 1909. Seen here is from Sachs's report of intraoperative X-ray, quote, deep therapy, with radiation applied to the tumor area, taking advantage of surgical exposure in order to overcome the poor tissue penetrating properties of the X-ray treatment units of those times. An important aspect of the work of the early radiation pioneers is their gradual elucidation of the principles of radiobiology. This is an excerpt from Coutad's report in the 1930s of his empirical discovery of the importance of fractionation in improving the effects of radiation. He's writing that little by little, by extending the treatment period from 30 to 90 days, by having small doses of radiation distributed in 2 sessions, they were able to obtain disappearance of cancers which had been previously considered radiation resistant. Also key to the historical development of the field were improvements in anatomical localization. This is an example of a pneumoencephalogram used to help plan the treatment of a patient with medulloblastoma. In an unrelated report, we see an example of a setup accessory consisting of grid-like plates fastened to the patient's head. Having trained with CT MRI and CT PET imaging all my career, I can't imagine the challenges of the earliest generation of radiation oncologists who are dependent on these technologies. The state of imaging and localization have improved greatly since mid-20th century. On the left is a 3T MRI scan here at UC Irvine, and on the right is an advertising image of the Gamma Knife Icon system. Another theme in radiation oncology's historical development is the search for novel radiations, such as protons and neutrons. These novel radiations are interesting by virtue of their unique physical or biological properties compared to conventional X-rays. For example, proton beams and other charged particles have the unique dose property of a sudden and high terminal deposition known as the Bragg peak. The sharp drop-off and absence of terminal irradiation beyond the peak makes them ideal for specialized applications such as chordomas, retinal or choroid tumors, and spinal cord tumors. Neutrons are known as a high LET radiation, in which the densely ionizing radiation becomes much more efficient at cell kill compared to conventional megavoltage X-ray beams. LET stands for linear energy transfer, and one can see on the plot on the right that the relative biological effectiveness which is compared to conventional X-rays, rises for LAT in the range of 10 to 100 keV per micron. Neurosurgeons and neurosurgical applications not only remain relevant in contemporary times, but in many ways drives innovation in the field of radiation oncology generally. For example, it was not long after radiosurgery, or high, very accurately applied single doses of radiation to small tumors, was developed for intracranial lesions, that the same concept was extended to the spine. Here is an early formulation of spine radiosurgery from 1996, showing a radiosurgery frame developed for the spine. Here you can see a skeletal fixation device utilized to guide spine radiosurgery. Contemporary spine radiosurgery is not performed with an external fixation device, but by utilizing highly accurate positioning and targeting techniques. Here is an early description by the Stanford group in 1994 of a radiosurgery device that would go on to become the CyberKnife. It was designed to be able to treat extracranial targets throughout the body. Treatment is given by a small linear accelerator mounted on a robotic arm programmed to move around the patient's body. An important, but unfortunately not as visually interesting, development are the many advances in computational technology and mathematics. For example, modern radiation therapy is oftentimes delivered with multiple beams, whose apertures are modulated by small metallic leaves or shutters interposed in the beam, and which control the shape and intensity of the beams. Arc therapy, also known as rotational beam therapy, maximizes the number of beam angles and leaf positions possible for treatment situations. Moreover, dynamic gantry dose rate further provides greater and greater numbers of beam solutions. This schematic can give a sense of the progressive number of beam solutions possible with increasingly fine beam samples and leaf configurations. Here are some examples of VMAT radiosurgery taken from my practice. Here are two examples of stereotactic radiosurgery for extracranial applications, oftentimes referred to as stereotactic body radiation therapy, or SBRT. In essence, radiation oncologists were desirous of repeating the successes of cranial radiosurgery, but to other disease sites. In particular, they took the lessons of the higher radiobiological effectiveness of a single or limited number of doses and combined that with an insistence on neuronavigation-like accuracy to create SBRT, which has been productively used for primary and metastatic diseases of the spine, lung, liver, and prostate. Here we see on the left an example from my own practice of treating a liver metastasis with SBRT, and on the right side of one of my practice partners treating a pancreatic tumor. So successful has SBRT become that for many academic and private departments, SBRT has become an essential component of their clinical and sometimes also their research output. The figure on the left shows trends 2008 to 2014 drawn from a study of private insurance claims, showing that the use of SBRT is rising more quickly than other technologies. The figure on the right shows trends from Internet search term analytics indicating rising interest in SBRT above other advanced techniques. Reflecting on the importance of radiosurgery and SBRT to the field of radiation oncology, I, as a radiation oncologist, co-authoring a chapter on the history of radiation therapy and radiosurgery for a neurosurgery textbook, I'm proud to acknowledge the debt that radiation oncology owes to its shared history with neurosurgery, a shared history of which all neurosurgeons may be proud. Historians, even amateur ones, should be cautious about predicting which developments may find themselves worthy of inclusion in future editions of Yaumann's and Wynn Neurological Surgery. But I'm going to finish with my prediction that flash radiation therapy may be worth following. Basically, flash delivers conventional ionizing radiation, but at orders of magnitude faster than conventional systems are capable of. In other words, on the order of greater than 100 gray per second for a flash treatment compared to 0.1 to 0.2 gray for a conventional. At such high dose rates, researchers have found marked sparing of the normal tissues compared to malignant tissue. Shown here is an excerpt from the first in-human report of the use of flash to treat a patient, in this case, who has a skin lymphoma. The dose was 15 gray in 90 milliseconds, and it shows marked regression of the tumor with less dermatitis than would be expected from a single dose of 15 gray given with a conventional machine. I hope you'll take the time to read the entire chapter, either in the digital or the print versions. You'll learn about the common and important history that both radiation oncology and neurosurgery share in the treatment of neoplastic and non-neoplastic disease. You'll also learn about the technological and scientific development that have underlain much of the field's historical developments. You'll also learn about how fractionated radiation therapy and stereotactic radiosurgery form the radiotherapy backbone for neurosurgical practice. I also go over some of the experimentation with novel radiation applications, as we have seen in this slide set, and about how radiosurgery, invented by neurosurgeons exploiting their experience with stereotactic localization and tissue ablation, has had a major impact on the field of radiation oncology, not just for cranial, but also for extracranial diseases.